Welcome, everybody. Good afternoon or morning, wherever you might be. Welcome to the April 2022 quarterly Arkansas APCD Data Users Group. It's our 11th session since we began, those many years ago. For those of you who are new to these sessions, the Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative, the ACHI, and is administered by the Arkansas Center for Health Improvement, or ACHI. The Arkansas APCD is comprised of private, carrier, and public payer medical, pharmacy, and dental claims, as well as enrollment data and provider data. Additionally, the HTI, the Transparency Initiative, enables the use of key data sets from the Arkansas Department of Health, including vital statistics data, aka birth certificates, death certificates, hospital discharge and emergency department data for those who self-pay or are uninsured, cancer registry data, and medical marijuana cardholder data. We also have some data from the Arkansas Workers' Compensation. We hope that you find today's session helpful. We invite you to ask questions using the chat throughout the session. We'll get to them as we can. And you can always reach out to our team after the session with any questions that you may have. So let's move forward, Kathy. Next slide. Great. I'm going to take myself off the video. Excuse me. All right. So here's today's agenda. And we developed this agenda using data user input gathered along the way, our own use of the data, questions from entities interested in the data. So our topics for today include our featured speaker, Dr. Brad Martin from UAMS, data request process review. This is an agenda change for when we sent out the invitations advertising the data users group. The original topic here was called Arkansas Demographic Distribution Statistics, but that wasn't fully baked, it wasn't ready. So we replaced it with this data request process review, which is timely because we've had a lot of questions and we thought we'd share some tips on how to apply for data and get it through the process faster. Then some data user questions from other APCDs and information about our latest release and data tips. We've put up another database with 6 more months of data. And of course, any remaining questions and discussions, remember, you can ask questions throughout. Some housekeeping between each section and at the end of the session, the question, yes. At the end of today's session, and I think it's in the chat too, you will receive a link to our service desk where you can enter questions and it'll be tracked. Arkansas APCD data, any APCD data can be complicated. You can also request time with our team to address specific questions, concerns you may have about how to use the data or interpret the data. The link to this deck, the one that we'll go over today, will be provided in a follow-up email. And then mark your calendars now. Our next data users group will be July 27th, 2022. Next slide. Presenters today are me, Kenley Money, Director of Information Systems Architecture and the APCD Director at the Arkansas Center for Health Improvement, ACHI, and Dr. Brad Martin, College of Pharmacy, University of Arkansas for Medical Sciences. Next slide. So our featured speaker is Dr. Martin, and he has his own slides. So Kathy is going to make him presenter, and he's going to take you through two projects that he executed using APCD data. He is very experienced at it, very knowledgeable, and has already done some publications with it. So Brad has agreed to share with us his insight and knowledge. Dr. Martin, take it away. I think you're on mute.
Yeah, thank you, and sorry, I'm trying to navigate all these screens that I have up right now. Thank you for having me and allowing me to share some of our work that has used the APCD data. And I'm going to present an overview of kind of two studies. These are going to be two vastly different studies, both in kind of the unit of analysis that we looked at, the files that we used for the ABCD data. So I thought I'd present these as kind of two contrasting to showcase some of the breadth that you can use with the Arkansas all-payer claims data. Some disclosures. The first study that I'm going to report on social network analysis received support from the National Council of Prescription Drug Programs. The second project that I'm going to talk about that looked at trends in hereditary cancer screening was supported by the UMS Translational Research Institute, which is supported by the NIH's NCATS. And then both projects took advantage of the Arkansas Biosciences Institute subscription to the ABCD data, and that's how we acquired the data. And then the persons that I received royalties or consulting income had no role in any of the studies that I'm going to present. So the first study was part of one part of a dissertation project by my former graduate student, Divyan Chopra, who's pictured there. We recently published this work, so if anybody wants to find additional details, they can go to the Journal of Pain. This was published last December. So fairly close to being hot off the press here in terms of this just being disseminated. And what we had tried to do or endeavored to do with this particular part of the study was to look at persons that are newly diagnosed with chronic pain, and we focused on back, neck, or joint pain. And what we really wanted to do was identify the social network characteristics of the providers that cared for these patients and try to identify those characteristics that led to opioid use or didn't lead to opioid use, or looking at those that went to opioid providers that prescribed opioids. So that's kind of the big picture of this, kind of starting with these people are newly diagnosed with these pain conditions, and then trying to follow them through their journey through this, and try to identify the provider characteristics that led them to either opioid use or didn't. Now, since this is a social network analysis, there are some terminology that comes with this field. So some of the characteristics that we were looking at, and I'm not going to define each of these or read these to you, but basically the N degree, centrality, clustering, betweenness, and closeness are all kind of measures of either how important a particular node is in a particular network, or how important that cluster is. And if you might think about social networks, and you may go back to your high school days and think about cliques, for example. So clustering is kind of a measure of kind of the influence of a particular clique within a network in there. So those are some of the measures that we looked at in building this social network. The data that we used, this is an ABCD report. So we used the ABCD data from 2013 to 2017. We identified patients in this were patients that were newly diagnosed with these either back or neck or joint pain. And we identified that first date of that as their first pain episode and defined that as our index date. Now, the network really looked at the providers that were caring for these particular patients. So what we identified in the providers in the network to be considered a provider in this network is that you had to have a visit from one of these patients, and that visit or that encounter had to have a pain diagnosis documented on that claim. So if a person with chronic pain, saw their endocrinologist for diabetes, thyroid disorders, and didn't have a diagnosis for back pain, that provider wasn't included in the network. So we were really trying to identify those network of providers that were involved in the care for these pain-related conditions. And we stratified the providers into primary care physicians, specialists, pain specialists, emergency medicine, and non-pharmacologic providers. You might think of these as chiropractors or physical therapists. And then we also stratified them into opioid providers and non-opioid providers. Opioid providers are those that prescribe an opioid to at least one of these patients in our network. So it's a pretty low bar to be identified as an opioid provider. So in order to form this network, basically, and I say we, Divian, generated this huge matrix of all providers that cared for these patients and identified the plurality provider for each patient. And that was the one that had the most visits for a patient. And if there were ties, we used a hierarchy. Like it was, a primary care physician, an emergency medicine physician were tied, had the most number of visits. We assigned that to the PCP. We identified referrals, and these are going to be called edges in our network, and those are going to be our connections between providers by seeing common patients. So here again, we're kind of trying to identify for each patient their journey through the different providers. The easiest way to identify the providers is that there is a referring provider on each claim. When that was populated on a claim that had one of these pain diagnoses, I used that to identify a referral between providers. Most claims do not have the referring provider populated. It's not a required field in order to have the claim. And most claims reimbursed, so it's often missing. So how we identified referrals in those instances is that we looked for subsequent claims with these pain diagnoses within 90 days of each patient. So if there was one and 10 days later, we assumed that was a referring provider. And then if there was another one 40 days after that, that was a referral for that one. And we've now built 2 connections between 3 different providers using that logic. We used a software specifically to graphically present this, GEPI software, to present these referrals. So here's what the population looked like. We identified 51,000, almost 52,000 patients that had either back, neck, or joint pain, newly diagnosed back, neck, or joint pain. And they were cared for by 7,123 providers. This is going to form the basis of our network. As you would imagine, almost over half were primary care physicians. The next most frequent were these non-pharmacologic providers, that's NPP. Those are primarily like physical therapists or chiropractors, and 9% were pain medicine. 64% of the providers were opioid providers or prescribed opioids. 65% of those were male, and the most common age was, somebody in their middle ages of life. So these over 7,000 providers, there were 325,000 different referrals between these 7,100 providers that cared for these almost 52,000 patients. The most common referral that we observed were between primary care physicians that accounted for 28%, and referrals between primary care providers and these non-pharmacologic providers accounted for 20%. And 70% of the referrals were involved an opioid provider. Next, I'm going to show you some graphs of kind of what some of the graphically these results look like In the paper, we present regression results that show the characteristics of patients that have the highest influence based on some of those network measures. So this is what a social network looks like. Now, this is a very, very busy network. And what we see here are clusters of providers within this. And within each clusters, we see that there are providers at the edge of the network and those that are in the middle of the network. These that are in the middle of the network are going to be more highly involved in referrals. They're going to have more connection between other providers with that, and are going to have more patients that are traversing through this network than these providers at the edge. Each of these clusters represent different geographic areas in the state. So this is a statewide look at all those 300 and some thousand referrals that are going through here. Is what this graphically looks like. And what we display here are opioid providers and non-opioid providers. And one of the things that you can see is that the non-opioid providers tend to be at the edges of these clusters or these networks here. So that's saying these non-opioid providers, those that aren't prescribing opioids, tend to have less influence in a network than those that are prescribing opioids. Here's a look, a drill down of persons that lived in the central region in Arkansas. So this is a little less granular. So it's essentially looking at this one cluster here. And this was for, these were the providers that we later identified were in central Arkansas. And here you can see a little bit closer look. You know, there are some providers that are at the very edge of this network that have very few connections with other providers. Then you can see most of the providers here have a lot of connections. But you can see here that along the edge of this network, we see a more non-opioid providers. Now to give a different view of the same central region, these are the different providers that cared, or provider types that cared for these pain patients. And you can see their relative graphically influence in the network. The closer you are to the center or in this area, the more influence these providers have. Those that are kind of at the edge here have less influence. So this is the same graph that I showed you before, but instead of showing you opioid and non-opioid providers, we're showing you the different provider types. And surprisingly, we didn't expect this, that these non-pharmacologic providers are kind of in the middle of the network. They have a fair amount of influence in terms of the referral patterns once somebody gets one of these pain diagnoses. Not surprising, primary care physicians are at the center, tend to be at the center of the network. Those that are kind of at the periphery are our pain specialists. They're not in central positions within the network. And some of the specialists are not at the center of the network. So some of the takeaways, and I didn't display all the results that led to these takeaways, but here's the main findings from these studies, that we find that opioid providers are more likely to be in central positions and have better reach than non-opioid providers. That was evidenced by higher levels of integrity, ID centrality, and closeness. High volume opioid providers were less likely to be in central positions compared to low volume opioid providers. So one of the things I didn't show, we looked at among opioid providers, what were their characteristics and stratified those between high volume providers and low providers. So what we find is that if you are an opioid provider, you're more likely to be central in a network, but as your prescribing volume increases, you're going to have less influence in that particular network. And one of the things that we found that brokers that connected opioid and non-opioid providers were more likely to be the, what are the most common physician type, middle-aged males. But what we also found is that chiropractors and physiotherapists were more likely to be in these central positions. So I'm going to pivot to another study, that completely different topic. And what this is going to feel more like a traditional study, and this is largely a descriptive association study, where we were trying to look at the trends associated with genetic testing for hereditary cancer risk over this time period. This is a different team. This project was led by myself and Kristen Zorn, and Mihir Bachira was the person who helped us draft initial reports and did a lot of the data work. So in this project, we sought to identify what were the trends over this time period for different types of hereditary cancer screening. HBOC stands for hereditary breast and ovarian cancer testing, so predominantly BRCA testing. Lynch syndrome, for those of you not familiar, that's a genetic syndrome that predisposes persons to GI cancers, in particular colorectal cancer. And then we looked at what are called tier 2 molecular pathology procedures, which are genetic tests that test for cancer, for mutations that are associated with cancer risk, but also include other panels of genetic tests that aren't associated with this. So these are kind of panel tests that include some markers for genetic susceptibility to cancer and some markers that might be associated with, like, for example, whether or not you're rapid metabolizer or might guide pharmacotherapy unrelated to cancer with that. And then we also built kind of a catch-all category of whether or not you received any genetic test. And we stratified that by whether or not you had commercial insurance, Medicaid, state employee, Medicare coverage. And the second objective was to identify what factors, who are associated with getting and receiving one of these genetic tests for cancer screening. So one of the things, and this is true for the Arkansas Bioscience Institute subscription, we get 6-month updates on the data. So obviously we use the data that's the most recent when we get that cut. But there is a lag of when some of the data are available. So Medicaid and commercial tend to be the most recent and freshly available. So when we commenced this project, we had data from January to June 2018. For state employees, we didn't have the last 6 months of that time period. And in Medicare, we didn't have the last 18 months. So one of the challenges that an analyst is faced with when they start a project, when they have these different, do we use a common time frame when we have representation from all the vendors or submitters, I guess, we use the APCD language here, and should we stop this in December 2016, or should we kind of have a staggered time period? In this study, we chose to have a staggered time period, but analysts may choose to say, hey, I want a common time period where I have data for everyone on this. So we chose the staggered one. Our subjects in this form, our denominator for our analyses that we're going to later do time series, and we looked for everyone that had at least 1 month of enrollment in at least 1 quarter during these time frames, and they had eligible for both medical and pharmacy benefits. For AIM-2, we were looking at enrollees that had 24 months of continuous coverage for both medical and pharmacy. And an additional inclusion criteria, because we were interested in looking at these genetic tests for cancer screening, not for cancer treatment, that they had to be free of cancer at least up until the period, either over the entire study time frame if they never had a genetic test, but if they had a genetic test, they had to be free of cancer prior to that genetic test. So here are the ways that we looked at the different procedures. Here's our hereditary breast ovarian cancer, Lynch syndrome. We also looked at And we were planning on presenting this, but these tests are done so infrequently that they weren't, didn't end up being reported. And these tier 2 are these non-specific tests that I mentioned. So this is how we classified the genetic screening that we looked at. Our measures here, what I'm going to show you are the quarterly rates of genetic testing. We're going to stratify those by plan type and then age and sex. We ran time series models, very simple OLS time series models that account for an AR1 or autoregressive first order autoregressive term. And to identify the trends, we included terms for linear and quadratic terms. The quadratic term is not significant, and we excluded that and report the linear trend terms. For AIM2, this cross-sectional analysis, we estimated separate logistic regression models for each type of genetic test, whether or not you receive those. And we included covariates that were based on demographics, comorbidity, some key mental health variables, nicotine dependence, and then also what area of residence you lived in the state. So here are the results of our quarterly screening rates. One of the things that you'll see in this panel, this is hereditary breast and ovarian cancer. The gray indicates the state employees. The blue are our persons that have commercial insurance. Yellow are our Medicare, and orange are our Medicaid. One of the things, here's our Lynch syndrome genetic screening. And in both of these, you see both the state employees have higher levels of genetic cancer screening. But when we go to general genetic testing, these are these tier 2 molecular procedures that we see Medicare represented here having higher rates of testing than employees. And we can see Medicaid is consistently the lowest, has the lowest screening rates of all the types here. And here's whether or not you received any genetic test. So this is kind of an average or accumulation of all 3 of these previous tests into one panel here, looking at these totals. And we can see Medicare and state employees having the higher levels of screening, followed by commercial insurance, followed by Medicaid. Now, one of the things, state employees, they are more likely to have be female and also more likely to be of kind of middle age. And those are the demographics that can be most associated with skiing. So what we're seeing here may not necessarily be attributable to a plan effect, but rather the demographic composition of persons that are going to be candidates for these screens. Here are the AIM2 results. What we can see is people age up, they are more likely to get screened for each of these. This row here, this is for hereditary breast cancer. Here's for Lynch. Here's for these tier 2, we're calling general tests. And then here's looking at any cancer screening. Not surprisingly, gender is a huge, very strong influence on whether or not you get screened. And so, you know, some of you may not know, males are also susceptible to breast cancer, far less so than women. But we can see that when we look at general testing, that actually males are slightly more likely to get screened. Here, not surprising, looking at the insurer types, our referent group is commercial, so that we see state employees are consistently more likely to be tested. Now, this is, you know, taking out and adjusting for age and the gender composition. So here we're seeing actually there appear to be plan effects in your chances of being screened, and Medicaid being far lower. And in some cases, you're only about 1/4 as likely to get screened as somebody in state employees. We see a fair amount of geographic variability. Persons that live in the northwest corner of the state are much more likely to get these screening procedures than persons that live in other parts of the state, with few exceptions. One of the things that we found that persons that had anxiety were more likely to get tested than a person that had other mental health disorders. Now, this is a cross-sectional study. We don't know if the genetic testing might be creating anxiety, or anxiety might be getting persons to get screened, but this is that association. And you can see with these model C statistics, we have pretty good discrimination across, for all these models. So takeaways from this work, we found that there were modest increases in genetic testing for hereditary breast and ovarian cancer, Lynch syndrome, across all our plans. So when we looked at the time series, we were seeing significant linear trends over time. However, the rates in Arkansas, when we compare this to data that we see in other states, is still lower than what we see in other states. And we find that gender, residence, and what type of plan you have are key determinants in that. And the fact that Medicaid enrollees are less likely to get tested suggests that there's some disparities here that are worth exploring, because Medicaid pays for these genetic tests. So it's not a coverage issue. It's the providers in counseling these different patients and accessing these services. I'm going to conclude here, and I'll be happy to entertain any questions. Let me go to full screen and see if I see any comments in chat. No, I don't.
We have one, were the nodes in the first study individual providers or also physician practices?
Okay, so good question. I see this now. Hey, Mandana. So for the most part, they were individual physicians. Now, we did include nodes where we couldn't, and they were facilities. But that represented less than 5% of the providers. So, it was an astute point. The vast majority appeared to be individual physicians, providers based on MPI, but for some, they appeared to be facilities. So we built a group called facilities, but that represented less than 5% of all providers we identified in the network.
Well, great. Thank you, Brad. We'll have this deck when we post the other slides. We'll include these, and everyone will receive an email after the data users group with the links. So, Kathy, if you wouldn't mind taking the presentation back and go to the next slide. That was great. I'd love to hear about data use. All right. It's 12:35. We will be efficient and go through this thoroughly and quickly. So this topic replaces, this topic replaces the aforementioned Arkansas demographic distribution statistics. Requesting data has many steps and requires a lot of interaction between the data requester, the APCD teams, and the Arkansas Insurance Department, AID. It's complicated by design. We have to ensure the appropriate use and management of the data being requested. That's why there's so many steps. We spend a lot of our time with data requesters making certain the application components are correct. So we wanted to review the process and discuss some common issues. We've experienced a few of late and provide some tips. So when you're ready to request data through the processes we're going to talk about, you can be ahead of the game. We're going to talk about a standard data request and then a subscription data request through ABI. Next slide, Kathy. So these are the steps for a standard data request, and a standard one is for a single user team for a single project. The ones that Brad had were ABI single use. The steps involved are, and I'll go through this quickly. You have an application submission, and there's bullets there to describe what happens. The requester submits the data request to us. We review, we work with it with the requester on edits. Then that once done, that application goes through an approval process through the HGI advisory board and then ultimately the commissioner. Once it's approved, then a data use agreement is executed. The insurance department does that. They invoice the data requester. Payment has to be received before we can begin fulfillment. Once that's done, fulfillment is executed by my team. We build the package and we deliver it to the data requester. And there's always conversation going on. We don't do this in a vacuum. Then the project execution. I'll get to that question in just a second. Project execution, data requester executes the project. And this next to last column here has a gold star on it because this is very important and is often overlooked, despite what is said in the application process and the data use agreement. Once your output is complete, or at least if you have an abstract that you submit and then you build a larger one, anything like that has to be reviewed and approved by the advisory board and ultimately the insurance commissioner before it is externalized. And that is so that we can ensure that the output aligns with the project, because sometimes it goes askew and then things have to change. And it represents the Arkansas APCD appropriately. And once you have that, then you can externalize your data however you want and propose to do. So the link here takes you to, we don't have to click it, but when you get this deck later, it'll take you to a site on our webpage that has all of these steps clearly outlined to help you through this process. Next slide, Kathy. Some quick tips for this. Be as deep, and these tips are a reaction to what we experience, and we always have to push back. Be as detailed as possible when describing your project. The downstream reviewers must understand how the data will be used and what the intended output is. You can include this description on a separate document if you wish. What happens sometimes is that we get a data request application and it has 3 lines in the project description. And that just isn't, you have to understand that this application is going to be seen by many people and get farther away from the requester, and the downstream people don't have any idea what those 3 sentences mean. So be as detailed as possible. There's a section in the application called evaluation criteria. There are 4 or 5 questions in it. Don't forget it. That's a big thing that's forgotten or omitted by data requesters. We then have to send the application back. Always include your project participants' resumes. And then, of course, as we said on the previous slide, you must have your project output reviewed before presenting it externally, even if it's not. Next slide. So this is called the ABI subscription data request process, and the data Dr. Martin used for his 2 projects came from the ABI subscription, the Arkansas Biosciences Institute. So what ABI has done, they have a subscription to the APCD. They have a copy of the all payer claims database that they house that can be used for multiple purposes that align with the Arkansas Biosciences Institute mission. There's a lot of flexibility there, and it's available to students and researchers from the UA systems and other institutes. Not every data requester can use ABI data. But the ABI process, and we have a lot, I bet we have 40 projects going with ABI right now. And the data request process for them is a little different, but folks get tripped up. So I want to go over it too. So if you are a student or researcher that has access, that can use ABI data, you submit your data request to ABI, and you'll see in that first column, that first asterisk, you would contact Dr. Robert McGee, and there's his email address. He'll review the data request, work with you to finalize it, and then sends that application to AID, the insurance department, who reviews and approves. And then ABI will notify you that your project has been approved. Then it's fulfilled. And as Brad said, ABI has they keep two versions of the APCD available. There's an older version and the latest and a newer version. And just be sure you know which version that you're using when you start to execute your project, because sometimes the newer version has resolved issues that are in the older version. And we get a lot of questions about that. And so we have to work with the ABI researchers to figure out what they're looking at. We don't control access to that. The Arkansas APCD team does not, but we can help point you in the right direction. So you execute your project, and then just like the other way in the other process, you have to have your output reviewed, even if it's just an abstract, before it goes, it's externalized. So that's just a quick reminder of what to do. I hope that's helpful to you. And you can read this in more detail when you get the deck. So let's go to our next topic. I'm gonna zip through here pretty fast. Oh, I'm sorry, the tips, same as before, detailed descriptions, two versions, output review. Next slide. So I'm going to start including periodically questions from other APCDs. So there are more and more states have APCDs. There are 18 in production, Arkansas among them. 8 states are implementing APCDs. An additional 8 have strong interest. States with APCDs can be very different. Arkansas is different than Florida, is different from Colorado, etc. However, there are many similar questions, and data users in and across these states have similar questions. So let's go to the next slide. I'm going to feature 2 questions from Massachusetts. I don't know that they're directly related to anything we have in Arkansas, but they're interesting nonetheless. So Massachusetts has a group called the Monthly Case Mix Work Group. And that is just the same as our data users group. And they publish their decks on their website. And this particular link takes you to the deck from which I pulled this question. I would suggest that you go out and look at the Massachusetts APCD site. It's full of very interesting information. Massachusetts is a very mature APCD. It's been around a very long time, one of the oldest in the country. So the question here is about how to identify athletic trainers within the claims data. So let's go to the next page. Next slide. Well, this is very dense, so let me just translate it for you. In summary, athletic trainers are defined by the National Uniform Claims Committee, NUCC, and by National Athletic Trainers Association, and they are assigned the taxonomy code that you see emboldened there. So let's go to the next slide. So whatever data user asked this question from Massachusetts was interested in the top procedures by athletic trainers, and this is the result from their query. This is from Massachusetts. The top 10 CPT codes. So just for fun, I did it for Arkansas. Let's go to the next slide. And these are the top 10 CPT codes from Arkansas and the number of unique claims across all the submitters. And so to get this, I went to our provider data table. I found all the NPIs associated with that taxonomy code. I took those NPIs over to the medical claims, and I pulled all the medical claims associated with providers with that taxonomy code. And then I did a frequency on the CPT codes. A lot of them are the same, but it was interesting to me that we had it was a fairly healthy amount of athletic trainer claims. So let's go to the next slide. One more look before we go. Well, how many claims by year, and using a similar process and the year of service date. This is a distribution of those claims over the past few years for athletic. Again, I don't know of a burning question about athletic training, but it shows you what other states are thinking about, and it's an exercise you can use with other taxonomy codes. Let's go, and an example is the next one. Massachusetts also asked a question about birthing centers. And there's a link to the deck from which I pulled this question. Let's go to the next slide. And they define birthing centers using these taxonomy codes. So I took these taxonomy codes and I looked for them in our data. Next slide. And these are the claims that I have. And I found it interesting that there were no doulas in the Arkansas data with that taxonomy code. Now, admittedly, I didn't look for other taxonomy codes for doulas. I was just looking at these. I found it interesting that the Arkansas data has over 200 midwives and birthing centers listed in 42 states. We have claims from 42 states for Arkansas residents. And this is over the entire time. But most of them were, of course, by neighboring states. Texas, Tennessee, Missouri. Next slide. Top 10 procedure codes for these taxonomy codes. Many are the same as the other, as Massachusetts. And then let's go to the next one and just see for fun the distribution over the years. So if you are visiting the APCD site from another state and you see an interesting question, happy to include it. We always talk with other states and we'll pull out things that might be interesting, easily replicable in the Arkansas data just to tease, but do learn from other states as well as here, because there's a lot of knowledge, and APCD knowledge is growing by leaps and bounds. All right, let's go to the next slide. The last topic focuses on our latest release. Next slide, please. So we have just published the next 6 months of data. The last time we had a data users group, data was available through December of 2020. Now it's available through June 30 of 2021. And like every release, we update all of our support documents. You can click on this link to get release notes, counts, universe counts, etc. One of the question in the chat was about what was it, Kathy, about EBD data? Go ahead.
Are state employees' claims included in the commercial claims?
So that is part of a data tip, and so I'm going to ask you to wait 15 more seconds. So let's go to the next slide, because that's very apropos. All right, when you click on that link and you go to the release notes, and every time you are using our data, I strongly suggest you go to the release notes just to see what's going on. There is something new in this database that I want to make everyone aware of. So Arkansas Medicaid utilizes the PASS program. And PASS, what is a PASS? A PASS is the provider-led Arkansas Shared Savings Entity, and it's a new model of organized care created by Arkansas Act 775. It addresses total health care needs of Medicaid beneficiaries who have behavioral health disorders, BH, or intellectual developmental disabilities, IDD, and the purpose is to improve the health of those who need intensive levels of care, link providers, et cetera. Well, so Medicaid utilizes third-party administrators, private carriers to execute and manage their PASS claims. Thank you, Kathy. And we get the claims from these carriers, and there is a data tip 0047 that has explained this is a relatively new thing in the past year that we are getting these data. And this data tip 0047 provided information on how you can differentiate a Medicaid claim, PASS claim from the TPA. And it's important because the Medicaid PASS claim is very administrative and really offers no value to any work. And Medicaid themselves has said you probably shouldn't use that version of the claim, you should use the TPA's version of the claim. So to improve our ability to identify the Medicaid claim, because it's not as simple as matching on a claim number. And we found that paid dates and paid amounts, et cetera, don't align with the TPA. So they were absolutely don't use the Medicaid version. They provided to us Medicaid provided a supplemental file that allowed us to flag their claims the past claims so that we can omit them from data requests. So moving forward, our standard protocol will be to, when you order data, is to certainly give you the TPA claims if that's part of your universe, and not the Medicaid claims that match. If indeed you want those Medicaid claims, we can talk about it, we can make them available, but standard procedure will be not to include them. So all of that's in the release notes and also in data tip 0047. That data tip includes the old way to do it and the new way. The old way is still viable. This is better. All right, now let's go to the next one. So don't forget, look at your tips. Next slide. And now we're going to get to the EBD, the data tip. So remember, the data dictionaries are updated, the tip sheets, the data tips are updated. Our hospital data and ED data have new comorbidity elements. So all of that's updated, and you can read about it in the release notes. And we've begun to, 2 months ago, we started something new. We have begun to send out a monthly email with featured data tips and issues. And Kathy, can you click on that? Will it go to that? If it doesn't, that's okay. The data tip.
Hold please.
I sprung this on Kathy. So.
Can you see the featured tips page?
Yeah, that's the featured tips page. Okay.
Okay, and we want a particular tip. Go forward.
Well, actually, I was hoping the email would come up, but we'll just talk about this. So the email that if you haven't received it and you want to receive it, let us know. We'll put you on the distribution list. And it's going to take you to some individual tips, but also this page. What we've done is created like the featured tips, the ones we've updated, added, resolved in the past 30 days. So you don't have to dig through all 200 data tips to figure out what changed. And you can get here by clicking on the red. Let's go back. So the red data tips, when you go to the data tip page on our website, you'll see this red new data tips and issues, and click on that and that'll take you to the feature claims. And the email that I'm talking about will get there as well. But hopefully that you're on our distribution list and you can get our monthly email so you can stay up to date. Because there are some data tips that are buried way down in there that are very helpful. And I can see where they might get overlooked. So I'm looking at the time. Yes, the recording will be made available. All right, Kathy, go back to the EBD question, please, since we're in data tips.
Are state employee claims included in the commercial claims?
Thank you for asking that. There's a data tip about that. So yes, there is some overlap because state employees utilize TPAs. They use some Qual Choice and some Blue Cross Blue Shield, and those TPAs do submit claims just like EBD, which is state employees. So we recommend that you utilize the EBD claims. The submitting entity code is 99EBD1, but go to your data tips and do a search on EBD 99EBD1. That's their code in the search box, and read about the TPAs and the claims that both entities submit. And it will give you, thank you, Kathy, it will give you advice on what to do. I'm sorry I brought that up more than once. I got ahead of myself. So we have 4 minutes remaining. Urge you to go look at your data tips. Does anybody have any questions? Let's go to the next slide, Kathy. You can ask us questions here. You can email us directly. And this deck and Dr. Martin's will be made available, and the recording of the users group. Is that handy, Kathy? That's okay. You can get that. Kathy and I didn't rehearse this impromptu request. That's okay. All right. Well, sign up for the newsletter, the ACHI newsletter. Keep abreast on Facebook, Twitter, LinkedIn, and our next group meeting is July 27, 2022. I thank you and have a great rest of the day. Oh, here's a question. Yes, we will. So reach out to us and we can absolutely do it. We recently completed one for the health department, the Arkansas Department of Health. Happy to do it for you. Whomever. Okay. Thank you, everybody.